thank you so much for having me. It's a great opportunity to share knowledge about a topic that has been misrepresented a lot. And I want to take this as an opportunity to educate and to clear up a lot of misgivings. And I think this is a very good group to be talking to: parents and teachers, people who work with children and who work with other parents, so that you can learn and carry the messages forward. And I'm also looking forward to a lot of discussion on some of the things that we're going to raise today in our presentation. So thank you very much for all those people who are able to attend. All right, so today we're going to discuss the human virus. As Grace has so kindly said, I'm a pediatrician, been practicing since 2007, so that's quite a few years. And I must say that I really enjoy working with children and parents. I think that's enough about me. So let's get into the nitty-gritty. Today, I wanted to cover a few of these areas. What actually is the human papilloma virus? What does it mean in terms of public health to all of us, our children and those people, the elderly people? So what actually has it meant so far? We also know that there are some vaccines for human papilloma virus. What are these vaccines and what's the history behind them? We also want to know who should get it and why. And by the end of this, we should have some rough idea of the risks we are running and the benefits of the vaccination. I also want us to touch a bit on the controversies, and then we'll open the floor for questions and answers. And I'm sure there will be many. I'm hopeful there will be many. Okay, so what is the human papilloma virus? Human papilloma virus is the most commonly transmitted sexual infection in the world. We don't hear that much, we haven't heard that much about it, because most of the time it causes warts and they heal on their own. But the reason why this particular virus has gained importance is because of its link with the causation of cancer. So there are over 200 types of human papilloma virus in circulation that have been identified. And 14 of these have been typed as high risk because they're associated with one or the other form of cancer. The HPV group of viruses are DNA viruses as opposed to RNA viruses. They are viruses that are transmitted by intimate contact, and especially where there is a breakage in skin, and then also through the mucous membranes. So it's not a casually transmitted virus. It is one that occurs during sexual contact. The initial infection can cause warty growths, and some can be very painful and unsightly. This can be at the point of contact, and they can also spread locally, and also by once the patient's own fingers can move the virus around onto their own body. So most infections occur in the early years of sexual exposure. Why would that be? It probably is because the person who gets infected is naive. They have never faced this particular type of virus until this point. And so by luck, if they get a mild one, good for them. If they get a serious one, we can't really choose which type of human papilloma virus we are exposed to. So in the beginning is when we get the most infections and the ones that progress the most, because of the fact that our bodies are completely unaware of human papilloma virus at that point. So most of the infections, 9 out of 10, heal on their own with the help of your own immune system. Except for there are certain types of human papilloma virus, particularly there's type 16 and 18 that have gained prominence, that damage the DNA of the individual, creating tumors in certain areas. So that's a reason why we want to really know more about this HPV. Now, because it's a virus, we don't have an antibiotic that reliably treats it. So what we end up having is either you heal or you have a chronic infection, depending on your immune competence, your general health. Not all of us are in optimum health. There are some who are diabetic. There are some people who have HIV, and there are others who have, they are on medicines for autoimmune disorders, diseases that make them need steroids and things like that. So not everyone is able to clear the human papilloma virus on their own. So as I mentioned earlier, type 16 and 18 are the ones that have been associated with cancer. And the cancer which they are most well known for is uterine cervical cancer. This is cancer that affects women only. There's the human papillomavirus type 6 and 11 that are associated with serious warty infections that affect the mouth, the oral pharynx, the anus, the penis, the throat, and can also cause tumors in the airways and lungs. So these are the 4 types that have gained a lot of prominence because of the vaccine. Right, so what really does this mean in terms of the health generally of people around the world and how much we spend on treatment? So human papilloma virus causes 7 out of 10 cases of uterine cervical cancer in women. And this is actually a very common cancer. It is the 4th commonest cancer among women in the world. So with, sorry, okay. And 4.5 of all cancers worldwide are caused specifically by this particular human papilloma virus, out of which, sorry, I've mixed it up a bit. 4.5% of all cancers in the world are caused by human papilloma virus, which gives us 630,000 cases in 2018, the last time this was published by the WHO. Cervical cancer is the 4th commonest in women, and we had 570,000 new cases diagnosed in 2018. Out of these, over 300,000 women died, and most of them occurred in LMICs, lower to middle income countries like Kenya. Now, why this is perhaps because women have less access to healthcare. Also, they're less likely to have screening done to them, and the diagnosis usually ends up being late. And once it is late, even the modalities of treatment are not as accessible in the lower to middle income countries. So this I put in just so that we can see the impact of the cervical cancer worldwide. And you can see that East, Central, and South Africa are the worst hit parts of the world. So this is really our problem. When we look at these other images, the first one, the one on your left, is showing us the distribution of the anogenital cancers caused by human papilloma virus. Now, this is both men and women. Again, Eastern Africa is well represented here, but we can see this one is more widely distributed all over the world. For some reason, the head and neck tumors are not as commonly diagnosed in Africa as for the other that are caused by HPV. I don't have a good explanation for this, but perhaps we also are not underdiagnosing them, and people are perhaps coming in late. So we can't really be sure that we are ahead of the curve as far as the head and neck human papilloma virus is concerned. So now about the vaccines. Human papilloma virus vaccines have been available since 2006. So that's about 15 years now. And that's a number I want you to keep in mind. It's an important number. So I'll tell you why later. The vaccines are made up of particles resembling proteins of the virus. These have been, they have used another virus to replicate these things, these proteins from the virus. And so they are only pieces. They are not actually complete virus and are unable to cause an infection. So we are giving you what is, as when you're given the virus, you're given pieces that are important in the entry of the virus into the system and the causation of disease, but they are unable to actually cause the disease. Along with these pieces of virus, we have things called adjuvants. And the adjuvants in both the human papilloma viruses are aluminium hydroxide. Aluminium hydroxide has received a lot of airtime as well as a toxin, but actually it is used as a drug, as an antacid in large quantities. In the vaccine, it is in very small quantities and it has a specific purpose there. It's making sure the particles of the virus are stable, they don't dissolve, they don't precipitate out, they're well mixed inside, and also the aluminium hydroxide stimulates the human immune system to give a sound response to the particles that are given. So we have two main vaccines that are on the market in Kenya. One is called Savarix, that contains only two of the types, human papillomavirus 16 and 18, which are actually the most important two types, which received its approval in 2009 from the FDA in the US. And then there's Gardasil, which contains materials from the two others that cause serious warty infections, 6, 11, 16, and 18, which was actually approved earlier in 2006. So there's 15 years of experience with it in the market. People have used this one a lot. Now, both these vaccines are available locally, but Gardasil is available through the extended program of immunization through the government of Kenya, free to girls 9 years and above. So this has been since October 2019. Now, both these are highly effective vaccines, and their effectiveness is in that they help the individual to clear the infection very quickly. So we don't have the chronic infection that goes beyond 2 years, whether you're a person who has some immune deficiency or not. But once you have been exposed to the human papillomavirus vaccine, you are less likely to end up with a chronic infection. So you may be exposed, but you're unlikely to get very sick. And the effectiveness is over 90%. We know so far, with our 15 years of experience with Gardasil, that more than that, these vaccines, the immunity lasts for more than 10 years. So that when you measure antibodies and immunity in people serially, you will find that they are still actively able to resist infection 10 years down. Now, remember that as a child becomes an adult and becomes sexually active, they will come across human papillomavirus of other strains. And so there will be an element of cross immunity. So they will have immunity not only to the dangerous types of human papillomavirus, but to others as well. And this will keep their antibody levels high. But right in the beginning, we need a good antibody level to prevent a serious infection. And then beyond that, it may actually be self-perpetuating immunity. So far, the studies that have been done show that there may actually be no benefit in repeating the vaccinations to people who have received the initial course of this human papilloma virus vaccines. Okay, so usually the timing is another point of a lot of controversy. A lot of people are unhappy that we have to give young girls and boys this vaccine at the age of 9 years. Now, remember we said that when the body is naive is when you are likely to get the worst infection, the one that you may not actually clear, the one that may end up causing cancer. So we want to actually equip a child with immunity before they are likely to be exposed to any of this human papillomavirus. as we had said earlier, this risk is the highest at the onset of sexual activity. So we want the vaccine to be in your system and you to have generated an immune response well before that point. So therefore, that is the rationale behind the KEPI, the Kenya Extended Program of Immunization, recommending this vaccine for children 9 years and above, or 10 years and above, for girls specifically. Now, globally, the global authorities have recommended this vaccine for both boys and girls, because boys too suffer from the various types of genital cancers and throat cancers that can be caused by human papillomavirus. Although girls and women are more heavily affected, boys too are affected. So you will find that most of Europe and North America have included both boys and girls in their immunization programs, and it is offered to all the pre-puberty, both genders, boys and girls. Now, once you are 26 years and above, the vaccine is not recommended, because by then it is likely that a person has been exposed and they have already developed some antibodies, and it's possible that they have some cross immunity. However, if somebody wants the vaccine at the age of 26 years and above, there is no harm in getting it. There may be little benefit, but there is no actual harm in getting the vaccine. So the vaccines are delivered as very small volumes, 0.5 milliliter doses into the muscles. And these may be given, there are either 2 doses or 3 doses. So there are 2 schedules. Either the vaccine is given on the first day and then 6 months later, or it can be given on the first day, 2 months later, and then 6 months later, for both the types of vaccines. So the 2-dose schedule is good for the children who are under 15 years old. And so studies have shown that they mount a good enough response when they are administered 2 doses under the age of 15. Once a child is over 15 years, we want to give them 3 doses, because this is now when we will get an adequate immune response. So it makes good sense to finish the schedule before the age of 15. So you have a good window between the ages of 9 and 15 years that will reduce the number of injections to 2. Now, this vaccine is not without side effects. All vaccines and all medicines that we take, they may have some negative effects. And both vaccines commonly, this is not an unusual thing, they commonly cause some pain, some redness, some swelling where the injection was given. There may be some fever, there may be body aches and malaise. Those of you who've had the COVID-19 vaccine must have experienced similar symptoms. And then with Gardasil specifically, there has been a higher than usual occurrence of dizziness and fainting. Now, although this dizziness and fainting has occurred quite frequently, it has not resulted in a permanent disability or injury to the child most of the times. So as the people who are administering these vaccines, we are aware of these side effects, and we usually want to observe the child for 15 minutes after vaccine, the child or the adult. Now, the dizziness and fainting is most common in the teens and in the prepubertal children. Adults don't often have this dizziness and fainting side effect. Basically, we want to overcome the side effect by observing a child and not allowing the child to go away until 15 minutes have passed and we are sure they are stable. Now, immunization against the vaccine is thought to provide greater than 90% protection against cancer, chronic infection, and then the resulting cancer. Now, the problem, remember I told you about 15 years. We've only had 15 years of experience with this vaccine. And the children who are given the vaccine, the people who are given the vaccine are around 10 years old. So 10 plus 15, those children who were given the vaccine in 2006 are now about 25 years old, but the peak time for infection with for detection of uterine cervical cancer is later. It's at around 35 to 45 years, and it gets more frequent with greater age. The average age of diagnosis is 50 years. So we haven't actually been able to yet see the full impact of this vaccine. It has only been with us for 15 years. What we have seen is that human papillomavirus will circulate less because people are able to manage their infections quickly and efficiently. Their body's immune systems are able to clear the infection quickly, which is good for them. They don't have chronic infections that can cause cancer. And it's good for other people in that they don't transmit the virus. So that's a point that I really wanted to bring out. It's unlike the other vaccines that we use, like the diphtheria, pertussis, the polio, the measles vaccine. We cannot really measure the full effect of this vaccine until another 30 years since the time the vaccine was given have elapsed. And the prevalence or the risk of developing uterine cervical cancer has actually been measured to have been reduced. Okay, so women worldwide have an average risk of developing this cervical cancer of 13.1 per 100,000. So 13 women per 100,000 women will in their lifetime develop cervical cancer if they are not immunized. In East and Central and South Africa, the rate is closer to 40 women per 100,000. So this is very many women. In 2020 in Kenya, statistics showed that 11.9% of women who were diagnosed with cervical cancer died from it. And it was the leading cause of death from cancer for women in Kenya. Although breast cancer is more common in Kenya among women, more women died from cervical cancer than from breast cancer, perhaps because breast cancer was detected earlier, or perhaps because there were more modalities for treating it that were available more widely. My guess is as good as yours, but we had a lot of death from cervical cancer. So we cannot actually be very certain about these figures because there are a lot of people who never even reach health facilities for various reasons, distance, cost, and may have reached and not been diagnosed or misdiagnosed. We also have an issue with Pap smears. So part of the tools for fighting uterine cervical cancer are Pap smears and colposcopy, which my colleagues obstetricians will tell you is the periodic viewing of the cervix to make sure that there are no changes that are suggestive of cancer. And the earlier you find these things, the better for the person, the patient, so that they can be treated and be cured. But because there is limited access to Pap smears in our setting, that we have people who get diagnosed quite late. The other thing with Pap smears is that they're very unpleasant, and the culture is that women are sometimes unwilling to go for regular Pap smear examinations. So these are some of the reasons why we are behind the curve a little bit in terms of cervical cancer diagnosis and treatment. So for us, primary prevention is a very good way to go. Just to give you a rough idea of safety of the vaccine Gardasil, which the government is providing, since the beginning, since the approval by the FDA and until 2017, in 2017, Gardasil 4 was replaced by Gardasil 9 in the United States, which has an extra 5 strains of human papillomavirus. So the data from the United States, where they are very good with documenting side effects, tells us that after 23 million doses of Gardasil were distributed, they had about 33 cases per a million. They had in total 772 serious adverse effects. These serious adverse effects were those that resulted in either permanent injury or death, or some serious other complication, like a life-threatening adverse effect. So we had 772 out of 23 million doses of Gardasil that were delivered, which gives you a dose of a risk of approximately 33 among 1 million doses delivered, versus the risk of 131 per 1 million chance of developing cancer worldwide. For us in Kenya, that's 400 per 1 million, or something around there, a risk of developing cancer, cervical cancer. So as you can see, it is around the world, it is 4 times less risky to get the vaccine than to not, because if you don't get the vaccine, your risk of cancer is much more likely, is much higher. We can also see that in our situation in East Africa, the difference of 33 and 400 is very huge, more than 10 times. So if you're thinking about risk and benefit, the benefit of protection is huge. The potential of protection is huge, I should say. So I want us to go away with these key points: that human papillomavirus is a highly contagious sexually transmitted virus, and it is associated with the majority of uterine cervical cancer, which is a very common cancer in women. And it's also a very common cancer in women in Kenya, more likely in Kenya than in Eastern, Central, and South Africa than elsewhere in the world. We have 2 highly effective vaccines that have a potential to prevent most of these cases of cervical cancer, as well as other cancers in the anogenital region, in the mouth, and in the throat. The greatest impact is if the vaccine is given before someone is exposed to this virus. And as we have seen, the available vaccines are overwhelmingly safe. After millions and millions of doses, you get hundreds only of reported side effects. A thing perhaps I didn't point out, the 772 cases that were reported in the United States were the total number. Some were investigated and some are coincidental. So there is no certainty that the 772, all of them were caused by the Gardasil vaccine. Some of them may have been other illnesses that someone had that manifest at the same time as the vaccine, so they were coincidental. So we can't really even be sure. 772 is a higher sort of an estimate of likely severe side effects. All right, so these are the main things that some studies have shown that people are concerned about with this vaccine. One is the concerns about safety. So there have been, as I told you, there have been a few serious adverse reactions. Some people have developed syndrome that resembles polio. It's called Guillain-Barré syndrome, a syndrome whereby someone becomes paralyzed and weak. Now, you will know that we know that any medicine has a few side effects, and in the process of stimulating immunity, a vaccine can also stimulate autoimmunity. So it can stimulate the production of antibodies against your own tissues. So if a very small percentage, not even 1%, but much, much less than 1%, so extremely, overwhelmingly rarely, do people develop autoimmune antibodies that affect their nervous system. So that was one of the issues. And unfortunately, the people who were affected, instead of having this investigated and treated in health facilities, resorted to campaigns on social media. And so you see, despite their overwhelming minority, they created a very bad image of the whole vaccination campaign. The other concern that parents have raised with me is the question of, is this a necessary vaccine? I mean, they say, oh, my children have been given so many vaccines. When I was a child, I was given a few vaccines. So as science has progressed over all these years, we have found more and more diseases that are vaccine preventable, and vaccines that are safe have been able to be manufactured and distributed. And these vaccines, the fact of the matter is the manufacturers and the medical fraternity and the regulators are fully aware that you're giving a vaccine to a well person, and you want to avoid giving them illness. So when they go through trials, the risk to benefit analysis is usually one of the top concerns with the regulators. So when you think of the benefit, if there is a small risk, the regulator has weighed it against the huge benefit of the vaccine. So we can see that if this vaccine that has already been delivered works well, in the next 30 or so years, the girls who received their vaccines in 2018 in Kenya will not be developing the cervical cancer that is killing women as we speak. Now, there's another group of people who don't just know about the human papillomavirus at all. And I think that's the reason why we are here today, to educate ourselves. So I think I may have helped a little bit, but I don't know. I'll need to hear your questions so that we can address more issues that you may have. And then the other one, that the reason why people don't actually get vaccinated is because we as health workers, we don't recommend this vaccine to our patients. So I want to urge my colleagues who are on the call that this is an important vaccine. We need to educate our parents, we need to support them to make good decisions, and we need to recommend this vaccine. I think I want to thank you all for listening so patiently, and I would like to request if there are any questions, and I would like to request Grace to take over again.
Okay, thank you so much, Dr. Rumesa. That was very informative.